thank you for joining us. Today, we will be discussing the low back pain's missing piece, diagnosing the sacroiliac joint. We appreciate your engagement in the discussion today and invite you to submit your questions for Dr. Ameglio to answer at the end of the presentation. To submit a question, expand the control panel on the side of your screen and type your inquiry directly into the questions field. We will try to address all questions at the end of the discussion as time permits. I would like to now turn it over to Dr. Ameglio, who will lead our session today.
Hello, everybody. Thank you for joining me. I appreciate taking this time in the afternoon when we're all maybe a little weary from our workday, a little tired. This is a topic that I am very passionate about because it's one that I think we've kind of long forgotten. When back pain was first thought of and studied, it really was the sacroiliac joint that was thought of as to be the primary cause of low back pain. And I'll talk a little later on about where that structure actually is in the human body. But it wasn't until studies were written later about pinched nerves and bulging disc that we really lost that focus. And since then, really it's been forgotten and undertreated. So I want to bring that awareness back to the sacroiliac joint because I think there's a lot of people out there suffering with this pain now unnecessarily. So I'm Peter Ameglio. I'm an orthopedic surgeon. I bring a unique perspective to this problem. As an orthopedic surgeon, I treat not only the base of the spine of the sacroiliac joint, but I treat hip arthritis, knee arthritis, other lower extremity ailments. So I really bring a unique perspective because most of the surgeons treating sacroiliac dysfunction are neurosurgeons. So they really just handle the spine. So I can really help to determine the pain that is coming from the sacroiliac joint, say, versus the hip, for example, or the low back. My background, I trained at Albert Einstein in the Bronx, and I also went to the University of New Hampshire prior to that. My mother is from Portsmouth, New Hampshire, so that's what brought me to New Hampshire. I was born and raised in, well, I was born in Washington, D.C., but I was raised in Central America, in Panama. So we're going to talk about the impact of low back pain. We're going to talk about a little bit about the anatomy. So hopefully those that are attending will understand a little bit about what could possibly be hurting them in their low back. How common is this SI joint dysfunction or sacroiliac joint dysfunction? And we'll see where that structure is in the human body. What causes it and what does it feel like? And most of the attendees there could probably tell me this, but if what I tell you sounds like you, then it's a possible diagnosis for you as well. How do we make this diagnosis? What are the treatment options? And throughout this webinar, we have time to answer your questions as we go. So don't be shy about asking your questions. And here are the numbers. And so for those of you that have signed on, you're not alone. 15 million office visits annually. Second only to the common cold in office visits. It's quite common. And it's the 5th ranked cause of hospital admissions. And this is the direct cost of taking care of this back pain. As far as the anatomy, this is a view of somebody from behind. These spinous processes, you can see my little cursor here, you can feel underneath your skin, these little bumps. There's 7 cervical vertebrae, 12 thoracic, 5 lumbar. The sacroiliac joint is here at the base. It is the shock absorber for the spine. So it really supports this entire column. And it also transfers weight from the spine around the pelvis down to the lower extremities. Excuse me, let's go back down to the lower extremities. Here's the hip joint. So the force comes down this way, around and down, and vice versa. Between each vertebral body or vertebra, there's a disc. That's the one that everybody talks about. Do you have a pinched nerve? Could that be causing your pain? And between each one of these, there's a disc. But it's almost become our sole focus now. And we've forgotten the very large sacroiliac joint down here that is very commonly the cause of pain. This, we don't have to get too much into the anatomy. We'll just stop there, unless there's some specific questions about that. The sacroiliac joint, we have where we put our belt, there is the iliac crest, a part of the pelvis. It would be actually in the back, not in the front. This is actually supposed to show a video, but some patients, I'll just use this to illustrate that some patients can present with pain in the front of the hip and solely with pain in the front of the hip, and it's still a result of sacroiliac joint, which is in the back. And that's because the front of the joint can cause pain and can cause pain in the front, the side, the back. It can even radiate all the way down the leg. Some people will call it commonly sciatica. The anatomy of the sacroiliac joint is quite complex. So this is looking from the back. So these are ligaments that support the sacroiliac joint. And the sacroiliac joint, here's the iliac crest. That's where you put your belt. Here's the spinous processes that you can feel in the center of your back and your low back. But this has to support your SI joint, these ligaments. So we find that any kind of injury to these ligaments can leave the sacroiliac joint unsupported or dysfunctional and result in pain. These yellow structures here are nerves. This is the sciatic nerve. Goes all the way down the leg. So anything, if this joint, the sacroiliac joint, becomes inflamed, becomes dysfunctional, there are not only nerves on the back that become painful, but in the front of that joint that become painful as those nerves course down the leg. That's what gives you that sciatic type symptoms. Other things that can cause the SI joint to become dysfunctional, anything that loosens our ligaments. So women that have had children or are about to have a baby, they release relaxin, the hormone that actually loosens your ligaments so that you can actually deliver the baby through the pelvis. That can make your SI joint dysfunctional. How common is the sacroiliac joint dysfunction? Estimates are from these studies from 1987 to 2009. The patients with chronic low back pain, 15 to 30% will have a sacroiliac joint dysfunction. So the important thing to learn about this is that it's not uncommon for you to have low back pain, which may be a result of narrowing of the spinal canal. You can have sacroiliac joint dysfunction. You can also have hip arthritis. And all of these things can actually either be in combination, or you may just have sacroiliac joint dysfunction as the major component of your pain. So it's really important that the surgeon determine what is the main cause. But the take-home message on this slide is how common, if you have low back pain, up to 30% of patients are going to have sacroiliac joint dysfunction. Now, if you've had surgery, you've had screws placed on your lower back for a fusion, a spinal decompression, if you've heard these terms when you've gone to your doctor, then that number goes up. Now you get up to 43% of patients with sacroiliac joint dysfunction. So if you've had low back surgery, then your chances that you have a problem with your sacroiliac joint goes up. So certainly something to think about and look for. Common causes of the SI joint. If you get arthritis, that'll stiffen this part of your low back. Here's the low back looking from behind. Here's the hip joint. So if this becomes stiff, either from arthritis or from surgery, it'll put more strain on the sacroiliac joint. That's what's highlighted here in the red. Any kind of injury that'll cause a fracture to the SI joint, that can cause arthritis, which is wear and tear of the articular cartilage there. Anything that can damage the cartilage, can damage the ligaments, can damage the muscles, which aren't pictured here, that support the SI joint. All of those things can cause SI joint or sacroiliac joint dysfunction. We mentioned pregnancy and childbirth. That's because of relaxin. All these ligaments are not going to support the spine as well. A fall, again, any injury to the bone, to the ligaments, to the overlying muscles that support the base of the spine can cause sacroiliac dysfunction. Lifting, because again, when you lift, you're applying more force to your spine, and again, that force has to be translated down the spine, down the leg. It's going to put more force on the sacroiliac joint. And of course, repetitive injuries. One other thing I want to mention is, which is not mentioned on this list, hip replacements. If you have a hip replacement down here, you end up with a limb length discrepancy. That can put more strain on the sacroiliac joint as well. That can cause SI joint dysfunction. And that's one that I commonly see. SI joint dysfunction can mimic hip arthritis pain. So that's something to keep in mind, especially because you want to make sure you don't have any unnecessary surgery. You want to have the correct diagnosis. So how do the symptoms present? This is what I find most interesting. Any of these little X's, patients can present solely with groin pain. And we would think that's nowhere near the SI joint. That's in the front. The SI joint's in the back. But I've seen patients just with this symptom complex. Typically, we think of that as hip arthritis pain. Careful examination, diagnostic injections may determine that to be sacroiliac dysfunction. I've had patients come in with lateral leg pain as their sole presenting symptom. SI joints back behind this model here. They can present with leg pain and it can be sacroiliac joint dysfunction. More classic presentation can be like the right-sided model. You hurt right over the SI joint, which is here, and it radiates all the way down to your foot even. That's what we sometimes call sciatica. That's another presenting symptom. There are many things that can do this, so it's important, again, for your doctor to be able to help you navigate. Is this hip arthritis? Is this from a pinched nerve in the back? So mostly it's for your doctor to try to help determine what is the source of pain. I'm trying to bring awareness so that at least that topic of sacroiliitis is brought to the table at the time of your examination with your doctor so that they don't miss that diagnosis. Another one I see commonly is patients that are this feeling of leg instability, buckling, giving way. I see patients even fall frequently because the base of the spine isn't properly supported and patients fall. That's one that is unexpected to me, but you can see frequent falls with sacroiliac dysfunction. Other symptoms, these I think we know there's a lot of overlapping symptoms: pain, numbness, tingling, weakness. All of these things are perhaps some of you may be feeling. This picture is frequently what I see when I come into my exam room. The patient is really trying to get off of the sacroiliac joint that hurts them. They sit to the side. And that's pretty telling sign when I walk into the room and I see that they're coming in for low back pain. That's a common way that people will sit. They can't sit for long periods of time. They can't take long drives. A lot of them will frequently have stiffness in the hamstrings, a muscle back here, because pain will cause you to not move properly and to maintain your flexibility. Sleep becomes disrupted. Every time you try to roll over onto that side, it hurts. When you're going from sitting to standing, also can become painful, because now you're transferring the weight from the lower extremities through the hip, up through the SI joint to the spine, and that loads the sacroiliac joint, causing pain. Difficulty ascending or even descending stairs. Going up and down stairs is another common symptom that people present with. So this is what I was mentioning at the beginning. It's being rediscovered, if you will. When we as medical community were learning about back pain, really it was kind of the only game in town. Most people were thinking of sacroiliitis. It wasn't until papers were written on the pinched nerve that our focus turned to pinched nerves. And some of you may have heard of facet arthropathy, or the different symptoms, different terms that you hear. You may have had your facets injected. You might have had an epidural injection. All these treatments are not for the sacroiliac joint. And if you had those and you continue with pain the way I'm describing, then you could have sacroiliitis. That's why it's important to rediscover this. Mostly trying to get the word out there, you do not have to live in pain. It's just a matter of finding the correct diagnosis and remembering that this is a major component of people's pain. Again, as I was saying, for those who have had surgery, up to 43% will have sacroiliac joint dysfunction. Those without surgery that have low back pain, up to 30%. So these are pretty big numbers. The tricky part for the practitioner, for the medical provider, is that a lot of these symptoms overlap. That's why a lot of people suffer with pain for such a long time. Because it would be easy to think, well, let's just get an MRI, scan your whole body, and then figure out what's going on. But really, if it were that simple, but it isn't. So sacroiliac joint dysfunction, problems in the low back, problems with the hip, all of these things can overlap. The symptoms can overlap. Proper diagnosis is very important. For example, I've seen patients with hip replacements that have had revision surgery because it was thought that their hip implant was loose, when really it was the sacroiliac joint. So clearly very important to try to make the correct diagnosis. This is how a lot of people will present. They will point directly to the sacroiliac joint. Some of us have a little dimple here, you point to it. That's a telltale sign for me that that's a potential problem. In addition to that, this is very effective in making that diagnosis as simple as it is, because that joint is right underneath the skin. But some of these other maneuvers, they're helpful, but if you don't have them, it doesn't always mean that you, and this is my opinion now, it doesn't always mean you don't have this diagnosis. I think what happens is we see somebody with pain, we don't necessarily want to apply the amount of pressure necessary to cause pain in somebody there. So we might not press as hard as we need to make a positive diagnosis. The number one diagnostic indicator is this injection, number 3. We use the fluoroscopy machine, which is a live X-ray, which allows us to identify the sacroiliac joint and place a needle right within the joint with a little contrast to make sure we're in the right spot. And then we place an anesthetic, just like you would if you went to the dentist to get some dental work. We numb the area. We know you're in your sacroiliac joint. We're now applying an anesthetic. If your pain goes away 80 to 100%, we have a diagnosis. We like to do that on 2 occasions to make 100% sure, but the patients can typically tell me that within 5 minutes, maybe 5 to 10 minutes. There is some room for confusion with that test because a lot of times we'll do the injection, the patients will get 80 to 100% relief, but then the pain comes back. So that does not mean that that's not the diagnosis. It just simply means the anesthetic wore off. And frequently, what I like to do is use the anesthetic with a steroid so we can provide some relief, hopefully long-lasting relief. But even if the pain comes back, it doesn't mean that's not the diagnosis. It just means the anesthetic wore off and the steroid didn't reduce the inflammation enough to give you long-lasting relief. So these are the different indicators of how we make the diagnosis. This is called the Fortin finger test, which doesn't really, the name doesn't matter, but basically the patient's pointing right to where they hurt. Now, they don't have to have this. As I mentioned in a few slides back, I've had patients with groin pain, lateral thigh pain, lateral leg pain. All of them have sacroiliitis, or I have confirmed sacroiliitis on an injection. So this might not be the thing that bothers you the most. You could still have that diagnosis. It's just a matter of listening to the story and deciding whether a SI joint injection is indicated to make that diagnosis. Ultimately, that's how we can tell with more certainty. Typically, the pain is here, we're saying below L5. What that means is where you put your belt, typically the pain will be below the belt or below the iliac crest, which is that rounded bone that you feel on your sides, kind of next to your buttock, if you will. These are the different tests, and there won't be a quiz at the end, so don't worry. But what your surgeon is doing, or your doctor is doing, is they're pressing on your pelvis to put a little strain on the sacroiliac joint to produce pain. These tests are a little tricky because you may have to produce a fair amount of pressure to produce pain. I personally am not in the pain business, so I'm not really putting a ton of pressure there, just enough so I have a sense that I'm on the right track for the diagnosis. So this is one of the maneuvers. Here's another one. Here's another one. But this is a cross section of the pelvis, kind of looking. Well, this is how for women, this is where the baby travels out through the birth canal. So you can see you need to have relaxant to open up the pelvis for the baby to travel through there. Here's the sacroiliac joint. So here's another test to apply pressure to the sacroiliac joint. This is another one, the Faber test, where we put the patient in a figure of 4. That's a very good test in my hands of all of these to determine that somebody has sacroiliac dysfunction, because you can really put very little pressure on the knee with the leg in that position to produce strain in the SI joint. And here's some other ones, compressing the pelvis laterally. Now, if you were to try this at home, that's why I mentioned that they're not always diagnostic, because you have to really apply quite a bit of pressure, and I don't think there's too many out there that want to produce pain, so me included. And here's a drawing of what the sacroiliac joint injection would look like. We actually have an X-ray, and we are able to see the iliac crest where you put your belt, and we're able to see the needle enter the joint. We place a little contrast within the joint so that we know with 100% certainty we're in the right spot, and then we put the anesthetic. This is a very important diagnostic tool. I have the machine you saw a couple slides back, the C-arm, in my office so that I can perform the procedure myself, and I can see the response or the relief. Aside from being very rewarding for me, I'm sure that whatever further treatment we offer, we're offering the right treatment. After that injection, here's some numbers we're looking for as far as relief. I'm really looking at 80 to 100% in most patients with this diagnosis. It is really dramatic, and it's incredibly rewarding. So anybody who's been out there with chronic pain, if we think you have this going on, we've had patients really cry tears of happiness when we're able to eliminate the pain so quickly and come up with a firm diagnosis. Once we inject it, we can have somebody step up, do different maneuvers, but you have to get down from the x-ray table, and just doing that produces enough strain at the base of the spine. And people can feel the difference getting down from the table and then walking out to checkout area or getting back into their car. Non-surgical treatments, I think this will make sense to most. Pain medicines, but not just pain medicines, but Tylenol, non-steroidal anti-inflammatories, chiropractic treatments, physical therapy. The sacroiliac belt is basically a belt that will go around the iliac crest and the low back. You cinch up tight to try to provide some stability for your SI joint, where your ligaments aren't doing the job. Then this provides some more stability. The injections can be used as a treatment as well. We put a steroid, and if you get lasting relief from that, that may be all the treatment you need. Then there's radiofrequency ablation, and that's where you put small probes near the nerves that give sensation to the SI joint, and you either heat them or cool them to the point where they don't deliver a pain signal anymore. That is not a permanent solution. The nerves will heal and the pain will return. Typically, you get 6 months to a year. And it's also not as effective as some of the other surgical treatments that I will mention later. Here's a picture of the SI belt going around the pelvis. You cinch it up to give you some stability to the SI joint in the back. Physical therapy for those who have had children, stabilizing, it's not mentioned here, but I find stabilizing the floor of the pelvis, so pelvic floor stabilizing exercises. For the rest of us, proper body mechanics, working on your core strength, which is not just the abdominal muscles, but the muscles that surround the entire spine, front to back. Proper gait training, some of these we don't have control over. If you had a hip replacement and you have a limb length discrepancy, you could try a lift to try to equal the limb lengths. If you have poor balance, you can work on the balance and just the proper sequencing of movement. Cardiovascular conditioning, I think, also refers to if we have some excessive weight and it might be affecting our lumbar spine posture, putting more weight on the SI joint, be helpful to lose weight as well. We mentioned this before, it's the same slide where we use the injection for therapeutic purposes. I will use the lidocaine, like your dentist does, to anesthetize the joint under fluoroscopy. I know 100% I'm in the right spot, but I also add a steroid, which is a strong anti-inflammatory, to reduce the inflammation in that joint. So there I'm looking to diagnose, but I'm also looking to try to give lasting relief with the hopes that perhaps that's all the treatment that will be needed. Here's a depiction of the radiofrequency ablation. They look like needles, but you can heat the needles or cool the needles near the nerves that give sensation to the SI joint. The problem with that is that the innervation, or how this joint feels pain, if you will, is very complex. It's not only in the back of the SI joint, but in the front of the SI joint, coming from below and coming from the top. So it's very difficult to deaden all the nerves so that the sensation to that joint completely goes away. When it works, it's a great treatment option. It can be repeated every year because the nerves do regenerate, so the pain does tend to come back. If everything fails, there are surgical options. And the option I'm presenting today is the iFuse option. Now, this is a last resort. And we always make sure that we have examined the lumbar spine or the low back with an MRI. We have examined the SI joints and the pelvis with an MRI or a CAT scan. We have examined the hip joints, all the reasons that could potentially cause you pain in that area. We want to make 100% sure there's no other potential cause of pain. We're 100% certain that this is the source of your pain. And we've done 2 diagnostic injections that give you 80% to 100% relief. In that circumstance, when somebody's quality of life is not what they want it to be, then this is a fantastic option. And I'll show you why. This video is not going to show up, but here's the SI joints, here's the hip. So we can see this can cause pain that mimics pain from here, that mimics pain from the low back. This implant is triangular in shape. The details aren't as critical, but if you look closely, it almost looks like coral. The other nice thing about this design is when you put in a screw, for those that ever fixed anything with screws, if you toggled where that screw is going across, that screw will back out. It's designed to go in, but it also can come out. This does not have that spiral screw shape. So once you put it in, it's not going to toggle its way out. And you put 3 of these across the joint, it really stabilizes the joint. So as I was mentioning at the beginning of the talk, the SI joint is the shock absorber for the spine. This really stabilizes the SI joint so that there's no movement. The other thing is to mention, there are now, because of the success, in my opinion, because of the success of the iFuse implants, there are a lot of mimicking products. They're not all the same. Just because this works doesn't mean that another product is going to work. In some instances, I've seen some problems as a result of making that assumption. This has been studied, and I'll show you some slides coming forward. Over 40,000 procedures performed up to October of 2019. 10 years of clinical experience and over 75 publications. And this is why I chose to use this, not only because of the clinical background behind it, but what we see in these graphs. Here on this y-axis, we see 10 out of 10 pains. So most of the patients are up here, 8 out of 10. That's hard to live with. Down here, after the iFuse implant is put into place, this x-axis is how far out from your surgery you are. So once you put in the implant, you can see that the line drops. That's because people are getting better. Here's 0. So right after the surgery, they're around a 2, maybe a 3, some even at a 2, and some below that. So it's marked improvement. And then as far as patient satisfaction, these are all the different studies published, and the lettering is kind of small, but those interested could find the details of those at the SI Bone websites. But very high patient satisfaction. These studies were done comparing patients that were treated and those that were received non-surgical treatment, and then followed those patients. And this is a multi-center, so multiple centers allow us to have more patients to look at and see how effective is iFuse as opposed to either doing nothing or treating by other means, and not other surgical means, non-surgical means. So to know that we're actually impacting people's lives in a positive way, that's what we're trying to look at. If you don't have any surgery, and these are the people that I'm talking about that have exhausted all conservative treatment, they just, here 100, just like the other slide, the y-axis, this would be 10 out of 10 pain. So here again, they're 8 out of 10, hard to live with. Non-surgical treatment, that line doesn't really budge much. It kind of stays up here. So we're hovering between the worst pain ever, 10 out of 10, to a 6 or a 7. That's very difficult to live with. And here with the iFuse implant, you get down to 2 to 3. Now, if you take the patients that had non-surgical treatment and you fuse those patients, that's the purple line. Even 6 months of non-surgical treatment, now you still relieve those patients' pain. So these are pretty powerful because these are a large number of patients that we can see that we're actually remarkably improving the quality of their life. This slide essentially stays the same, says the same. And looking at, once we do that, so we know people get better quickly, how long does this last? Well, we're out 5 years. And I'm sure they'll put out the study when it goes out 10 years. But at 5 years, that is a sustained relief. The pain doesn't come back. That's also very rewarding to think about. You're not going to get better and suddenly you get worse. The indications and the risks, this basically, the indications are what the whole talk was about. We just have to make the proper diagnosis. And it's a history, physical exam. It's the diagnostic injections, which are probably the most effective way of making this diagnosis. And then it's a lot of imaging studies. So it does take a lot of time and investment on the patient's part to get better, only because we do need the MRI of the lumbar spine or CT. Some patients can have an MRI. We need to image the pelvis and we need to look at the hip because we want to make sure that we're doing the right thing. So that's how, once we have all those things in place, then we know we have the right indication for the procedure. The risks aren't really exclusive to iFuse. It's any surgery. Anytime you open the skin, there's risk of infection, blood clots, failure of healing, some pain and stiffness. So these risks are standard for all surgeries. So this is where I can take some questions and go into a question and answer session. And I thank you for taking the time.